Good evening and a very warm welcome to another episode of Master Techniques. Tonight, we have two distinguished speakers who are going to talk their experience and educate us about management of Talar osteochondral lesions. We had three Master Technique webinars last year on calcaneal osteotomy, open versus minimum invasive bunion surgery, and tarsal coalition. And this is our first webinar this year. If you want to send suggestions as to what you would like to have the next Master Techniques on, you're most welcome. You can send it on the chat function. Other housekeeping announcement. After our two speakers have given their talks, we will open up for discussion, and please use the Q&A mode for asking questions, and I'll present it to the two speakers. Also, there will be QR displayed for the feedback, and the code for that would be again in the chat function. So once you have done the feedback, which is really important to improve, you will receive your certificate for attending this webinar. So I would now like to invite our first speaker, Steve Hepple. He is a very senior foot and ankle surgeon, consultant at North Bristol NHS Trust, also honorary senior lecturer, done a lot of work on research, education, has keen interest in sport injuries. He has been actively committed to education and was in education committee of BOFAS for a number of years, and then became a treasurer, followed by being our president in 2018. Over to you, Steve, for your talk.
Thanks, Maneesh. It's very kind and very, thank you for the introduction. It seems to be a fairly esteemed group of people that have joined the webinar, so I hope we can answer some questions for everyone. I'll just start my talk. Oh, that's not right, excuse me. Share. That's not the one I was trying to share. Excuse me, sorry.
Don't worry, Steve, take your time.
Is that that's not sharing, is it?
Not at the moment, we can't.
Ah, here we go. Sorry, it's at the end of the talk. There we go. We finished the talk. We'll all go home. Sorry. Right. Okay. So you can see me now. So yeah, I'm sure the reason that many of you have joined tonight is osteochondral lesions are the bane of many foot and ankle practice, and I've been interested in them since I was a senior registrar, and my practice has continued through. And unfortunately, I don't think we have moved on as far as we would like to have done in 20 years plus, which is how long I've been looking at these. But we'll go through. I'm going to give you a short introduction and my theories about OCD, and then explain my favorite technique for dealing with them, which is just one possibility that you perhaps might consider. So what's the issue with ankle osteochondral lesions? Well, they're pretty common. We're all seeing them more frequently. I certainly am. Some literature suggests that they occur in up to 60% of ankle sprains, but if they are occurring that frequently, then many of them must settle down spontaneously. Some of the issues that cause problems are the fact that the ankle cartilage is fairly unique. The cartilage is thinner than in other joints, but it's also got a different biochemical makeup. There's also the poor vascularity of the talus, which can contribute to poorer outcomes in these. And then finally, and possibly most importantly, is the unusual shape of the talus. It's a pretty unique shaped bone. There are not many bones in the body that have corners like the talus, and that makes it difficult for us. There's also the issue of access to the ankle joints, which, because it's a fairly well enclosed bone. So one of my thoughts on osteochondral lesions is that I still think there's a dual pathology, and that there are two types of lesion. There's the common one, the traumatic one, which, you know, younger patients, usually they've got a history of definite trauma, a bad sprain. It's usually on the edge or the corner of the talus, and it's associated with a shear force. But I do think there is another group, which loosely I've termed osteochondritis dissecans. I'm not entirely sure, but there's an alternate pathology. There's something else going on, a vascular, hormonal, genetic problem. We often see them present a little bit younger in the second decade, and they may have had symptoms in their ankle for a while. And I think these are primarily a bone pathology. They're sometimes central. The reason I mention this is not because I've got any magic solution for treating them any differently, but I think the nature of the pathology here is such that they are completely different. One's traumatic, one's got underlying bone pathology, and therefore for us to expect the same treatments to work in the same way is probably a bit foolish. And none of the studies I've ever seen make this distinction. And so all lesions just get thrown into the same pot. And, you know, maybe this second pathology accounts for a reason why we don't get better results, or we're only ever around the 70 to 80% mark with our results and outcomes. But that's just my theory on it. So what sort of things do we look for with OCD? Well, obviously the characteristics. We need to know what type of lesion, whether it's a stable lesion, whether there's displacement of the fragments, whether where the lesion is on the edges of the talus or in the center, because that can affect the prognosis. And possibly most importantly is the size of the lesion. That seems to be the one factor that's coming out more and more in the literature as determining perhaps what we should do to them. So just another off-track issue really is what causes the pain in an osteochondral lesion? Well, I think some of them have a purely mechanical issue. So they've got flaps of cartilage or loose bone floating around in the joint. Then you're going to get mechanical symptoms of clicking, locking, and scraping. But actually, a lot of them seem to be pain from the lesion itself. And we know that cartilage is insensate, so it's not the cartilage. So it must be the subchondral bone, which has a dense innervation. So the current theory, most people believe, is that we get a subchondral fracture or a microfracture as a result of that shear injury. And that leads to penetration of fluid under high pressure. And eventually you get some cavitation or cyst formation in the subchondral bone. And this leads to undermining of the cartilage and subsequent fragmentation and collapse of the cartilage. And this can produce the typical appearances you see in these CT and MRI scans. So I think it's the subchondral bone. Oops, sorry, it's going backwards each time. So I mean, symptoms and signs, we all know these, mechanical symptoms, locking, instability, and sharp pain. With those type of lesions, when they present with those symptoms, I think there's usually a good outcome. We can solve a lot of these because those tend to be related to the loose fragments, which we can clean up quite easily with arthroscopy. But then there's those who present with the non-mechanical pain, which is often more deep-seated, more persistent, is not always activity-related. And they're the ones where I think we're struggling to help them. And they're ones that often bring us to secondary and tertiary type surgery. So obviously the signs, there's usually very little to see, but you do need to make sure you look for instability and hindfoot varus. It's really important because either of those associated with an osteochondral lesion, then you may have to deal with one or the other before you're going to get a good outcome. But I'm not going to talk about them any further. So imaging, obviously plain radiographs are often normal in up to 50% of cases. MRIs are bog standard. That's what we're using in most cases, and it's usually highly diagnostic. I use CT scan occasionally if I think there's a cystic lesion, a large cavitating lesion. And I use CT SPECT scan when I'm questioning whether the pain is coming from the OCD, because we see lots of patients with OCDs and we're not actually that convinced it's the cause of the pain. There might be something else going on in the ankle, or it doesn't sound quite right. And the CT SPECT scan can be helpful in those circumstances. Classification, this is the right reason I get asked to talk on these so often. Myself and Ian Winterson many years ago devised a classification system on MRI scans. There are others using X-rays, CTs. I think they're all useful for documentation, but none of them really have, even my own, have really shown any great help in deciding how to treat these lesions. I think the one benefit of the MRI classification is that it does indicate a prognosis. There's definitely a trend as you go up the classification for the outcome to be worse. So big cystic lesions at stage 5 give us the worst outcome. So the treatment options are widespread, and I'm not going to go through all of these. Pete's going to talk about several of them towards the end, but I'm going to quickly run through the first 3 or 4 and then focus on membranes, essentially. That's my chosen topic for tonight. So if we get an acute lesion like this, if we're lucky enough to see an acute lesion, then fixation with non-absorbable pins is perfectly absorbable pins or non-absorbable screws is perfectly reasonable. In 23 years, I've managed to do it 3 times, so it's not very common. The standard treatment for any late presenting OCD has always historically been some sort of bone marrow stimulation technique or microfracture. In fact, there's not much evidence in the literature to suggest there's any difference between microfracture, drilling, or curettage of the lesion. And there still remains good evidence that this should be the primary treatment in most lesions, and certainly lesions under 10 to 15 millimeters in diameter. Lots of papers have recorded 65 to 90% good outcomes. Obviously, it's essentially a band-aid, is how I describe it to my patients. It's putting a fibrocartilaginous plug into the defect, and hopefully the pain settles. There's no evidence that immobilization after doing a microfracture makes any difference. So I get all my patients going straight away. I do give them crutches. They don't, and I just tell them to weight bear as comfort allows. But I don't put them in a plaster or a boot afterwards. And the evidence supports that. Recently, there's been a lot of talk about injections. I think you can summarize it in that the jury's still out. People report some transient benefit from both hyaluronic acid and PRP injections when combined with microfracture. The evidence is still inconclusive, and it's not a routine part of my practice. So this is, I wouldn't say a routine part of my practice, but this is my next stage. I pretty much do microfracture on everyone as a first stage, but as a second stage, I've resorted now to doing these membranes. I started off 10 or 12 years ago doing a MACI technique, so that's matrix assisted chondrocyte implantation, which was basically a 2-stage technique whereby you do an arthroscopy, take some biopsies of cartilage from around the lesion, send it off to a laboratory in Holland, and they would send you back a membrane, a collagen membrane with chondrocytes apparently growing on it, and then you go back and reimplant them. Well, that's quite laborious and quite expensive. And these newer 1-stage techniques seem to have taken over and are much cheaper, much more efficient, and seem to give similar results. So these membranes, and there are several on the market, but my favorite is the Chondroguide. It's a bilayer collagen matrix, and you can get them in various sizes, but obviously in the ankle, the smaller size is usually enough. And there are different ways you can use this. You can use it as the membrane alone. You can supplement it with microfracture and then put the membrane on top. You can supplement it with bone marrow stem cells, the so-called MAST technique, which is taking out some bone marrow, spinning it down, and getting the stem cell rich element. You can add in PRP, and even more recently, and not on this slide, there are some papers out now, which I'll present towards the end, where you can just use concentrated peripheral blood. Some people have added hyaluronic acid as well, but again, that's not part of my practice. So just to illustrate how it is. Now, before I start this video, I will confess that it's not a video of the Chondroguide technique. I did have a video which wouldn't play on the computer. So this is my technique that I used to use, the MACI technique. But if you ignore the fact that the membrane is a slightly different color, the technique is identical. So I start off arthroscopically and debride one of the lesions there, make sure we've got a nice stable edge and that the underlying bone is not fragmented or cystic. We clear it out and tidy up the edges. And then once we're happy we've got a tidy edge and just probing down into the gutter there. At this stage, I'm now templating the lesion. Again, I'm doing this arthroscopically or very mini open. And I'm just going to pause it there. It's going a bit fast. Sorry. I'm templating the lesion with a little piece of aluminium stitch package. You can just see it glowing in the gut. So I'm working out the size of the lesion. And then I'm putting some fibrin glue in to seal off the lesion. Before we do that, we cut the lesion. So this is the MACI membrane rather than the Chondroguide, but the principle's the same. You cut out the patch, and then the patch goes in with a bit more fibrin glue around it. into the lesion. Now I'm doing this as a dry arthroscopy now. So I'm using the arthroscope to help me through a minimal access portal on the lateral side of the joint. So that's what it looks like to start with. And then at the end of the procedure, it will look a little bit like this. So again, it's a dry arthroscopy, so you don't get the clearest view. And then this is one I re-looked back in, and this is a chondroguide one. I looked back in about a year afterwards, and you can see it's not a perfect repair, but there is good cartilage formation. And these are the sort of incisions I'm using. So it's mainly arthroscopic, and then when the membrane is going to be introduced, it becomes a mini open procedure. So the evidence for using this procedure, there are lots of papers coming out about 10 years ago of people reporting this. And initially I was quite skeptical because the results in reality were not that much better than doing a microfracture. People were reporting 70 to 80% good. I was also skeptical of this particular paper from Maneesh Bhatia in 2013. And again, the results, encouraging, but not perfect. And he'd done 130 patients in the space of about 18 months. And therefore, he must have been doing every single OCD. Now, we know that quite a fair proportion of OCDs get better with a simple microfracture. And so, the initial results are skeptical. I was skeptical. All of these papers were case series. There's no control group. There's no randomization. They're all just what I like to do on the day. And so I think we have to take them with a pinch of salt. Over the years since then, and these next three papers are all in the last 2 or 3 years. So this is a meta-analysis that's done. Again, there's no randomized controlled trials here, but all at 4 years follow-up, AMIC seems to be a better procedure than anything else. It seems to be the better procedure at about 4 months. So AMIC, of all the procedures available that they studied, which were most of the procedures for OCDs. And then again in 2022, this is Maneesh Bhatia again. He's changed his technique. He's now just using peripheral blood concentrate. But again, in the space of just a year, he's getting 136 patients. And that's a huge number of patients. And so every single patient he gets must be getting this technique. And it's hardly surprising he's getting reasonable results, because we know that even arthroscopic debridement gives you reasonable results. And I'm slightly concerned that if he's got the ability to get that many patients in such a quick time, why has he not done a randomized controlled trial of one versus the other? And then this is an analysis of the mast, which is using the stem cells versus the peripheral blood. And there was no real difference at 2 years. So it looks like we don't need to take marrow out of the pelvis anymore. We can just use peripheral blood with the same technique. But these are all very recent studies. They're isolated studies. And then the final one is basically a 5-year follow-up study of the AMIC, showing again good midterm results compared to microfracture. So despite my initial skepticism 10 years ago, it does appear that the best evidence we have is slowly turning towards AMIC being better than microfracture alone. But it does. This one had an average size lesion of 2.7 centimeters squared. So it seems to be, certainly in the bigger lesions, there's enough indication out there to do this as a primary procedure. And in the smaller lesions, it's perfectly reasonable to go to to stick with the microfracture technique. Obviously, there's other options, and Pete's going to tell us about them in a minute. I'm just going to say a couple of things about evidence in the literature before I finish. I mean, there was this consensus meeting in 2017 where the great and the good of osteochondral lesions joined together in Pittsburgh, came up with a number of consensus statements. And there's a lot of good opinion from this, but not much science. But there's lots and lots of papers from this meeting in the literature. And you just have to take them with a slight pinch of salt, because they're all opinion rather than necessarily evidence-based. And it's interesting that E4 in their open review just last year made this statement that given the paucity of comparative research on OLT treatment outcomes, there are no specific criteria to guide the orthopedic surgeon to the optimal option, and treatment should therefore be individualized. The decision of which approach is most suited to each patient depends on the specific characteristics of the OLT. So really, just to reinforce the fact that 22 years on from when I first published on this, unfortunately, we haven't made great progress. And it's a real shame that all of us, me included, haven't really got together to do a proper randomized controlled trial of these techniques, which have been around for a long time now. But in any case, my personal approach to osteochondral lesions, pretty much everyone, unless it's a very big lesion, still gets an arthroscopy and a microfracture. That's pretty, you know, and the literature is possibly slightly going away from that now and supporting the fact that we can do AMIC in the bigger lesions, but this is still my practice. When I get a tertiary referral, I often consider the above because I do find there's a certain number of cysts that haven't been decompressed and they can be a pain generator. And there is some evidence of improvement with a second debridement. But then for a second line approach, I'm using the arthroscopic AMIC, and in younger patients, I'm putting some, up until now, I've been putting stem cells in from the bone marrow, but maybe I'll start using peripheral blood. I found this a relatively easy technique. There's no knee morbidity, and the evidence is definitely increasing. And then the third line technique is obviously other things. And that's all I've got to say. Thank you very much.
Thank you very much, Steve. That was a fantastic presentation, giving a very nice overview, management options, challenges, questions about evidence-based practice. So I'm sure there will be plenty of questions, which we'll take in the discussion session after our next speaker. So I'm delighted now to invite Pete Rosenfeld, who again is a fantastic educator and researcher and has a huge interest in sport injuries. He doesn't need any introduction, but those who don't know, he's head of foot and ankle surgery at Imperial College London and director and co-founder of the Fortius Clinic in London again. He's also sports medicine trainer for Western London and Oxford rotations. In 2012, he was the foot and ankle surgeon or doctor for the Olympics and Paralympics Games. And he has organized and taught on a number of courses and has been a founder and chair of Royal College courses for ankle replacements, anatomy, and arthroscopy. So, Pete, if you're ready, please, you're most welcome to deliver your talk. Thank you.
Thanks so much, Maneesh. I've got such fond memories the last time we were teaching together. It was a great course, so it's really kind of you to say those nice words. I'm going to talk to you particularly tonight about AOT, so autologous osteochondral transfer. Here we go. So hopefully you're all seeing this now.
Yeah.
Autologous osteochondral transfer, or I tend to call it OATS because that's what you've been brought up on. This was when I first got into it. It was 2003, and the sister in A&E came up and said, look, I've got this really sore ankle. And this was her scan back then. And she had this big cystic lesion in her medial talar dome. In fact, you can see it on the X-ray. You can see this cystic lesion sitting there. And I was fresh back from Australia. So I rang up Terry Saxby, and I think I texted him and said, Terry, can I send you these over? And he had a look, and he goes, his reply was, well, Pete, it's a big hole. Like, you better fill it with something. And that was as far as he got for advice. So I read into it, and I read into OATS, or autologous osteochondral transfer. And this is what she ended up with. Let me just get this out of the way. Excuse me. There we are. And that's what she ended up with. So that was my first OATS, and that was a medial malleolar osteotomy and a single plug. And those are her follow-up MRIs about a year and a bit later, because I wanted to see how well it was doing. And she did great. She had no pain, no problems, and it was a resounding success. I'm sure, had it not worked, I'd have gone off and looked at something else. So what's the evidence for using AOT or osteochondral transfer? Well, there's plenty now. And in fact, there have been some really good studies in the last, really the last 15, 14 years showing that large osteochondral lesions do badly with primary debridement and primary bone marrow stimulation. And particularly this one by Choi et al. In 2009. And they looked at 120 osteochondral lesions. They were treated by primary arthroscopy and bone marrow stimulation, whether that's curettage or microfracture. And they went back and looked at the ones that they had determined had failed. And failure was an AOFAS of less than 80, or those needing repeat surgery. What they came to the conclusion was that those with the size, there was a cutoff in size of 150 millimeters squared, which determined, so those greater than that size, 80% of them needed, had failed the requirements there. And it's gone on from there. So that's the reason for having 150 millimeters squared as your cutoff point. Now, I don't stick to that, and I'll tell you why. And a bit like Steve, I think you can still do very well with primary treatment, and there are reasons behind that decision. So this is the guy that started it all, Laszlo Hangeli, who ended up as professor at Semmelweis University, and he started osteochondral transfer. And these are some of his original slides. And the far slide you can see on the right is the borderline between his transferred osteochondral plug and how well it worked. And he was one that started. He started doing it on racehorses initially. That was in 1982, I think. So hopefully everyone knows the technique. And essentially, you have a bad area of cartilage, on the knee, on the femoral condyle, and you harvest donor plugs from the peripheries of the patellar facets, and then you insert the plugs into that defect to fill it up with some fresh graft. And this is where the term mosaic plasty came from, because you start to make these little mosaics to fill the hole. And then this kit was designed to do it, and this was called the Osteochondral Transfer kit. And so hence the term OATS, which is the osteochondral autograft transfer system, and then mosaic plasty. So how do you do it? Well, you can either do it through an arthrotomy or an osteotomy. It's quite rare to be able to do it through an arthrotomy, but if the patient is good enough and the lesion's in the anterior half and the patient's got a flexible ankle, you can plantarflex their ankle and either approach it medially or laterally. And in fact, this is an AMIC, that's not an OATS. But you need to have a good flexible patient to do that in. Most commonly, you'll do it with an osteotomy. Most commonly, it's medial. Rarely lateral. I've done very few laterals. And you can do a little anterior tibial window just to get to that one you can't quite plantarflex. And I think that's a useful technique. We'll talk about the most common one, which is medial malleolar osteotomies. And essentially, you want to expose the medial malleolus anterior and posterior, so a longitudinal incision, clear away the soft tissues, protect the tib post tendon that's closely applied at the back. And really what you want to make sure you do, and this is really important, is you want to make sure you expose the furthest, the most lateral extent of the OCD, or medial if you're going the other way. Because what you don't want to do is cut the malleolus and then realize you can't expose your talar OCD. And that's actually what I did in that first, that A&E nurse that I first did. And I had to recut the medial malleolus because I hadn't cut it deep enough into the joint to expose it. So I now scope the patient first. I then put in a K-wire and I make sure that K-wire comes out where I want it to, and then cut over the top of it. Pre-drill the medial malleolus, that's always useful. So you can fix it when you're finished. And then you want to saw over your wire to the subchondral layer and not through. And you can do a flat cut or a chevron. If it's not a very deep piece of bone, then I'll do a flat cut. And if I'm going in deeper into the ankle joint, I'll do a chevron because it makes the piece of bone a bit smaller and it keeps it out of the way of your exposure. And then you do the final break with an osteotome to break that cartilaginous subchondral layer. And we've seen this paper by Kennedy that says there's no complications doing this operation in over 74 cases. So it's a safe thing to do. Now, to approach the OCD, you need to get good exposure here. And this is about mobilizing your medial malleolus. So you want to release the tissues, both the anterior fibers of the deltoid and the posterior sheath of the PTT tendon. And because they'll stop you retracting your medial malleolus. So don't worry about mobilizing those well. And then pull your medial malleolus inferiorly. You'll need your incision to extend inferiorly a fair bit to achieve this. And then what I like to do is then just pin it out of the way with a K-wire and bend the K-wire out of the way, and it's held out of the place forever. And that gives you good distraction. This is one of the early ones. I used to use the laminar spreader, and you can see there is the osteochondral lesion. And when we prepare the graft site, what you want to do is size the lesion, and there's this blue tamp on the set, and that comes in different sizes, 4, 6, 8, or 10 millimeters. And you can then say, okay, I need the 10 millimeter set. Thank you very much. And you want to check your angle of access when you're doing this, because actually you can't, it's very rare to get it perpendicular. And so you always have to drill an oblique hole and an oblique plug, and which means when you harvest it, you've got to think of that angle as well. So there's a bit of eyeing the angle of the dangle when you do this. Then that blue tamp, or the blue sizing wire, has a hole down the middle. So once you position it centrally over your lesion, you then drill the guide wire down that, and that will put you in the center of your lesion. And then you have the reamer of the appropriate size to get rid of the bad cartilage, and a cylinder of the cancellous bone. Now, this is very important. Measure the depth of your hole so you know how deep and how big a plug to put in. So when you come to donor harvesting, this can be done arthroscopically, and I used to do it arthroscopically initially. It's a bit fiddly to do. It's nicer for the patient for sure, but it's quite difficult to get your plugs the right size and the right shape. And so I now do it open and use and expose this lateral femoral condyle and take the plugs from the periphery of that joint. And what we know is that there is an instance of knee pain, and we'll come on to that later. There's some more up-to-date knowledge on this. But what we also know is that the more plugs you take, the more likely that instance is. And James called that a paper out recently saying, actually, that 2 plugs is plenty. The ones that got knee pain were the ones that had 3 plugs taken from them. You can also take it from the femoral notch. And there's also a paper on taking it from the ipsilateral talus, which is quite interesting. So your graft size or your diameter, you want to take a graft that's bigger than 4 millimeters diameter. And the reason is harvesting it causes a ring of 0.4 millimeters of cell death at the periphery of your plug. So if you only took a 4 millimeter plug, that's effectively 1/3 of the surface area. So I never go smaller than a 6 millimeter plug. And now when you're orientating to put it in, I've always remembered this thing called long side near. And so what you want is your plug will always have one side longer than the other because you've taken it at an angle and you've drilled at an angle. And you want the long side nearest to you, because if you put the long side on the other side, you get a corner like that. And you can't pare it down because you end up chopping off all the cartilage and back to bare bone. And of course, doing it well and getting good congruency is better for the pressures and the long-term effects. So going back to length, it's very important that your graft plug is shorter than the tunnel you've drilled, because when you bang it in, you don't want to bang it too hard. Use this little tamp. It's very useful for banging in gently. That's on the set. But if you bang it too hard, you will kill all the cartilage on the top. So you don't want to bottom this out. So I tend to give a good 4 or 5 millimeters. I usually drill to about 15 millimeters, and I usually put in a 10 millimeter plug, or a 20 millimeter drill and a 15 millimeter plug. So I make sure I never bottom out. If you're putting multiple grafts in, they will sink. So when you drill one out and put another one in, you'll start to make the previous one sink below the height you want. So you'll need to pin them in place with little K-wires. So if you're doing nested or mosaic plasties, when you've done one, then you need to pin it with a little K-wire so it doesn't sink when you prepare the site for the other ones. The fixation usually is a medium malleolar, and it's just 2 screws that you've pre-drilled. If it's on the fibula, then you'll use a plate. And if it's an arthrotomy, just closure. Post-operatively, it's a little bit different. If I've done an osteotomy, it's 2 weeks in a plaster and then 4 weeks in a boot. If I've done an arthrotomy, it's straight to a boot. All of them are non-weight bearing for the first 4 weeks. This is the video of somebody at 5 years. Now, she had some impingement problems, really from scar tissue. So it gave me the chance to go back in and rescope it. And you can see here, these nice plugs on that medial shoulder are the ones I put in. You can see the round peripheries of them. But all the cartilage that I haven't replaced has started to fall away and die away. So she's obviously got some cartilage issue, but there are my mosaic plastic plugs after 5 years, looking beautiful. And there's 2 plugs there. So that's a nice example of actually the cartilage plug surviving beautifully. I'm not sure why that doesn't let me go forward to the next slide. Here we are. Results. This is a CT arthrogram of he's a chap with a pancreas and liver transplant. Lovely guy. So sorry, pancreas, a renal transplant. He's a lovely guy. He had some ankle pain. His MRI looked really good, and I didn't believe it was coming from his Oates procedure. So I got him a CT arthrogram, and what you can see here is the beautiful thick cap of the knee cartilage, which is much thicker than talar cartilage. And so that is that black area. But the contrast you can see is really covering it well. And there's no sign of that contrast getting underneath that cartilage layer or causing any other trouble. And that's one of the problems we have, is the difference in thickness of knee cartilage. Results. James wrote this really nice paper recently on professional or athletic populations with superb results and really quite large osteochondral lesions with an average size of 250 millimeters squared. 37 out of 38 returned to sports, professional sports. Some, I think 4 were at a level below the level before, but 34 of them had gone on to their original level of professional sport, which is quite phenomenal. He did notice that 2 had problems with their knees, and these both had 3 plugs taken from their knees. AMIC, well, Steve's done a very nice presentation on AMIC. I have done one AMIC, and it was on a doctor actually at Imperial, and this is AMIC of the tibia, and this is after I've put the strip of pig skin. I call it the porky scratching operation. So this is after I've put the pork skin on, and then we went on to do the talar side too. It was probably too far developed a case for this to be successful, and he actually hasn't done well. He's stopped running. He's managing on a day-to-day basis, but it hasn't been as good as he or I wanted. But I was probably extending the indications way too far. Here's a very recent paper with a 2 to 8 year follow-up. Again, they've got what they call good results, but 32 out of the 33 cases still had persisting edema on MRI at this 2 to 8 years. Only 1 had no edema. So there's obviously still some activation going on there with AMIC. And the OCDs were quite small, to be honest. The other thing they said was they had 58% reoperation for hardware removal, which I'm guessing meant they had ankle pain, and they've just called it hardware removal. So I'm not so sure with that. The other interesting part of the paper was that the cartilage, the MRI evaluation of the cartilage, the MOCART score, did not correlate at all with the outcomes. Other alternatives, iliac crest donor plugs. There's a recent paper on this, which is really just using the iliac crest and its periosteum to do the same job. They've actually got very good results. And they had big cystic medial osteochondral defects. It's a 4-year follow-up. So that's certainly very interesting to use. They were using these white chips, and these are BMP chips, bone morphogenic protein chips, hugely expensive. I'm not sure it's something that we're going to follow unless more comes out that's good there. And then also recently just using the side of the talus, so the non-weight bearing side of the talus, to replace the weight bearing surface of the talus. Again, these were only small primary lesions. I think they would have done just as well, if not better, with primary arthroscopy. And also, as mentioned, taking out small lesions and small cylinders, you get a lot of cell death. So we'll watch and wait on that one. Allografts, yeah, people are still trying them, they still don't work. So that's one option. So in summary, large lesions greater than 150 millimeters squared are good for AOT and osteochondral transfer. That's primary or revision. It's a really well-established technique now, and it's got superb results with long-term high return to follow-up, high return to sports, high return to function, and minimal donor site morbidity. It is a good option. Do I use it primarily? No, because I think primary arthroscopy and debridement, you can still get excellent results, and I will keep this as a reserve for that lesion, for that reason. Thank you very much.
Thank you so much for excellent talk, both speakers, Peter and Steve. And it's time for discussion now. And we are getting lots of questions from the audience. So can I please ask you to join me? Fantastic, thank you. Waiting for Steve. Okay, so one question which I would like to kickstart with, and there's also Nick Duncan has asked, he was thinking about the same question. Any tips on dealing with tibial osteochondral defects in athletes? So we know that tibial osteochondral defects have poor outcome, and how do we deal with them? So I'll start with Steve and then Pete.
Yeah, well, it's difficult. I mean, fortunately, they're the minority of lesions. I see about one for every 40 or 50, and ones that are definitely an osteochondral lesion rather than early arthritis. I think that's an important distinction to be convinced, because if you think of the mechanism we assume that causes an OCD in the talus, that really can't happen in the tibia. You can't get the shear force that you get on the corner of the talus. So you have to question whether it's the same etiology or whether it's just early degenerative change rather than a sort of traumatic OCD. I've tried microfracture, I've tried the membranes. I'm not sure that Oates is very easy to do on the tibia. I'm not convinced that anything's better than just microfracture. You might get away with it, but I think the prognosis is generally very poor for tibial lesions, and I've not got a magic solution.
Thank you, Steve. Pete, your thoughts?
Have you tried AMIC on it, Steve?
I've done it once. That's because I've been relatively conservative till now, and I've only come across one lesion where it's sort of suitable. But yeah, we'll wait and see. I can't give you evidence on it because I haven't seen it really. You've done one, obviously.
Yeah, I mean,
it was a kissing lesion though, so it was always doomed to failure, I think.
It was always doomed, but it was, let's give it a go. Yeah, I'm the same as you. I think I tend not to use microfracture. I tend to just debride the area with a curette and shave it, and I'll do the same with tibial ones. They've often got a cyst, haven't they? The ones on the medial malleolus, and they've got that little cyst that pops into the medial malleolus. So it's quite fun. You can stick the spoon into the cyst and really debride it very nicely there. So it's quite a simple procedure to do, and it's quite good fun to do. And probably, it's still successful. I don't think it's destined for doom, but they're definitely harder, and certainly the big ones are very hard.
Yeah. Okay, so the agreement is they're difficult lesions, but they're not. You can debride and see how it goes. Yeah. But in terms of Oates or AMIC, they're not very good candidates for that.
Well, I think practically it's difficult to do Oates on them. You can't get the access. But AMIC, the jury's still out. No one's really published on it, and no one will have done more than a handful of cases. So it may be a solution. It'll be more difficult to do, but it might be technically possible. So it might give us good results in the long term. I don't think we can say. So if you want to try AMIC, I think there's a license to try it, but I'm not telling you it's definitely a good treatment.
Okay. We move on. Thank you very much. We move on to the next question. So, Maneesh, can you please explain the difference between tibial osteochondral transfer and tibial osteochondral lesions? And how do you treat them? And what are the risks? So for microfractures, Steve, which lesions in your experience do better? That's a question from Mr. Gajula, medial or lateral?
Well, historically, lateral lesions always do better. They tend to be more superficial. The cystic lesions tend to be medial. And even if they're not cystic, the medial lesions tend to be slightly deeper and more cup-shaped rather than the lateral lesions, which tend to be more saucer or flattened. And I think the lateral lesions tend to do better with microfracture. Overall, as a group, the medial lesions do worse.
Yeah, I mean, I remember reading that paper, which was published from Bristol about beware of medial lesion. Is that your experience as well, Pete? Medial do worse?
I mean, there's so much more common. I think you get a bit blinded by how many medial ones you see, and the lateral ones get sort of swamped by your experience with the medial ones. I haven't, I mean, Steve's looked at them in numbers. I haven't actually ever looked at my numbers to say which is which. So no, I don't particularly, I'm not frightened of one or the other. And I'm still positive about it. You know, arthroscopy and bone marrow stimulation still has really good results in, 80 to 90%.
I think that's probably why you do most of your oats on the medial side, because the medial ones tend to be the ones with bone loss or cysts and things like that. So they're more suitable for oats, aren't they? And the lateral ones, I think, are very superficial, and they often do better with just a microfracture, and so you're not needing to do your secondary technique on them. So it sort of fits with your experience of mostly doing medial.
Yeah, absolutely.
That brings me to the next question, Pete. So you said that you don't do too many fibular osteotomies, but if you have a lateral lesion, then you can't access that with your medial malleolar osteotomy. So you're forced to do that, aren't you?
Well, you are. You've got quite a lot more exposure laterally, though, with an arthrotomy. So plantar flexing the foot, the fibulas at the back, and you can often get to a fair bit of the anterolateral talus. You can also release the ATFL. You can sublux it out. If you really want to, you can release the syndesmosis and go through there. I prefer to do the fibular osteotomy if you're getting to that stage of things. I think it's a nicer way of doing it. It's much like you'd expose a lateral talar dome fracture, and it's the same principles there. I wanted to ask Steve, actually, with your osteochondral lesions, when would you consider a calcaneal osteotomy or a tibial osteotomy, and what's your experience there?
Yeah, I've done both in small numbers. If there's malalignment, I have very low threshold for doing an oscalcis osteotomy because I think there's relatively low morbidity associated with that. Tibial osteotomy, I'm a bit more, needs to be a little bit more of a positive indication. So if someone's got a suggestion that their distal tibia is slightly out of line, and if you crank it around to the opposite direction, that's going to take the pressure off the OCD, then I'd certainly do that. I wouldn't do it as my primary technique, though. I would perhaps do it as a secondary technique combined with AMIC or oats if I was doing something else, just to maximize the outcome.
Yes.
But if I can realign the forces just with an oscalcis, then I might do that as a primary technique because I think that's relatively low morbidity.
So, and are you finding you're doing more, say, calcaneal osteotomies now when you're coming around for a second go at things?
I'm certainly looking for it more. I can't say I've done lots, but yeah, I'm certainly looking for it more. And I certainly look for instability. I've had a whole heap of lesions sent to me. Oh, they've got ongoing pain. Actually, this is instability, and the OCD is incidental. And you do have that paradox though, because just repairing the ligaments and tightening the ankle up, and therefore making the treatment of the OCD more difficult if you have to come back and do something clever to it. And there's always this debate of whether do we do them both together? Shall I do something to the OCD and the ligaments, or do I take a chance and just repair the ligaments? And it comes down to, what your appreciation of the symptoms are, and if you can decide, is this primarily instability type symptoms, or is this primarily from the OCD? And it's not always as easy as you think it might be to make that decision.
No.
Thank you both. We got quite a few questions, and I would like to cover as many as I possibly can. So let's get going with questions. Do you use microfractures and AMIC even if there are subchondral cysts?
Yeah, I do. I mean, if there's a massive bone loss, then I will definitely start thinking about Pete's technique, yes. But I mean, if it's a cyst and it's a relatively small, then you can bone graft. Some people like to bone graft them. I'm not that big a fan of bone grafting. I'm just happy to seal off the lesion. I don't think we're realistically returning the articular surface to normality with good functioning hyaline cartilage yet. We're not there yet. We're on the road to it, but we're not there yet. And so all you're trying to do is stop the pain, and things. So even if the lesion sits a little bit lower than normal cartilage, but it seals it off and stops the pain, that's good enough for me. I often tell people, these lesions are often about the size of your fingernail, and if we can just stop it being painful, the rest of the joint can cope often. And I think that's where we are with many of these lesions. We're not making them normal, we're just stopping the pain. And so I am happy just to graft with a small cyst underneath the ear, but not an excessive cyst. And so I'm happy just to put a membrane on a small cyst.
Good. We'll move on to the next question, and I'm going to ask both of you, Pete and Steve. This is regarding OCD in adolescents. So do you wait until they become adult, or you intervene whilst they are growing? That's the first question.
So, I mean, you definitely want to give it as good as go as you can conservatively. A lot of these, you do see lots of them in, young sporty kids, and they will settle down over a period of a year or so. So if the child can tolerate it, then that's the best thing to do. If not, then I haven't done it many times, but I've had really good success with retrograde drilling.
That was going to be one of the questions. So yeah, go on then.
So yeah, retrograde drilling, it always sounds lovely, and you get the probe out and you stick the probe on top of the soft bit of cartilage, and then you fire the wire up and it meets where the probe comes. But actually what happens is the probe is too big to fit in the ankle joint, and you can't get it to sit where you want it to sit, and because it's a kid's ankle, it's been designed for an adult ankle, and nothing quite fits in the joint. So what happens is you end up having a best guess, but actually you can do it very, very well. And you can use a very fine K-wire, use a 0.7 K-wire or something to work out your approach or your attack if that sort of ACL guide or that ACL probe isn't working, and then just under drill it. And if it's a medial side, you come from the lateral sort of sinus tarsi region, which is very nice, much easier to do. If it's a medial side, it's a bit tricky, and you've got to work out your way to do it without damaging anything too much. But yeah, it's been very successful in the small number that I've done it in.
Thank you. Now, Steve, I know for a fact, I mean, I'm going to ask you about adolescents, but also I think you published that saying that retrograde drilling is not a great idea, if I remember.
I was just going to say, I think it all fits together quite nicely, actually. This again is my theory, but when you saw in my talk, I talked about the two different etiologies. Now, those OCDs that are presenting in adolescence, I often think they're the ones that most likely have the alternate etiology. They're not the true traumatic OCD. Now, I think the true traumatic OCDs, the retrograde drilling is a waste of time, because if they're caused by the mechanism we described, there's a subchondral fracture, there is a communication with the joint. Now, the cartilage might feel intact, but there will be a microscopic breach in the subchondral plate, and there'll be a fissure in the cartilage somewhere, which will allow fluid to be forced into that cyst. So retrograde drilling, it won't usually fix the problem. And I think you just have to find the defect, and there will be a defect, and de-roof them and do it from above. But in the lesions that are caused by perhaps non-traumatic means, maybe a vascular phenomenon in the bone, then drilling might work, because that's essentially drilling for AVN or the equivalent of. And so that might be why you get good results when you do that in adolescents. I don't have any evidence for that, but it sort of hangs together, because I don't think you get good results when you do drilling into cysts in older people. I have to caveat that with the fact that I don't have a pediatric practice. I only operate on adults. So I don't have cases where I can say that's worked for me.
Thank you both. I think that does make it clearer. Next question is from Veronica. Now, Veronica, you asked about post-op rehab plans. I think Steve and Pete both mentioned about their post-op plans. I think Steve says that crutches and weight bearing is comfortable.
For microfracture, it's just get on with life as far as I'm concerned. The ankle likes to move, and movement is good for cartilage. I'm a little bit more circumspect when I do AMIC, because I think if they move straight away, they might just shear that membrane off. That's my paranoia rather than evidence-based. So I'll usually put them in a boot for a couple of weeks, but then get them going, just to give the fibrin glue time to stick down properly, and things like that. So it's more witchcraft than science, but that's what I do. So I'm very aggressive, but just that caveat that they're kept still for a couple of weeks.
Thank you. And Pete, you did mention when you do osteotomy, 2 weeks plaster and 4 weeks boot.
Yeah, that's really just for the wound care. To be honest, it's just to stop the wound, to give the wound a chance to recover over the osteotomy.
Fantastic, thank you. So Donatus has asked, Pete, do you use fibrin glue to seal the oats plugs?
No, not at all. They are so tight fitting. I mean, you struggle to get them in, and that's probably the hardest bit of the two hard bits in the operation are getting the orientation of your donor plug right, and the other thing is actually inserting it in the right rotation, because obviously the surface, your cartilage surface, is going to be slightly curved, slightly angled, slightly out of position. So finding the correct orientation for your plug is really important, and then trying to get it in. It's actually a very, very close press fit, and you slightly feel like you're having to hit it too hard to get it in. So rather than doing big blows, you just do lots and lots and lots of little taps, because you don't want to damage that cartilage cap. And the harvesting, I was going to give Nick Geary some praise here, because Nick gave just a fantastic idea, and a bit like the foil that Steve used for sizing his defects. He uses the foil from the suture packet, and he puts it over the talus if it's a shoulder lesion, to work out the contours of the talar shoulder, and then he exposes the lateral femoral condyle, and he gets his template and rolls it over the lateral femoral condyle until he finds the best fit, and that's the place to harvest his plug from. Beautiful little technique.
Excellent. Well, thank you very much. That's really nice to have that good tip from you. The next question, I have no clue what it means.
Nor do I. I don't know what that is. So the answer is no. I haven't got any experience with the use of it. I presume it's some sort of alternative fibre glue, is it?
Pete?
And actually, it's okay. It's another type of artificial plug. I've just Googled it. Okay, mainly in the knee. No, I haven't any use of that in the talus, I'm afraid.
Episealer.
Which one's this episealer? I don't know episealer.
It's basically they're custom implants, custom-made implants made of using it doesn't say what they're made. Oh, cobalt chrome. So it's basically like the hemicap.
That's a hemicap. Yeah.
Oh, okay.
So yeah, well, hemicap failed miserably. So unless there's something special about the episealer, I'm not that confident it'll work.
No.
I have got no experience there.
I've done one hemicap, and the guy had to twist my arm to do it, and it failed. So I fused him about 1.5 years later.
Okay. Actually, there was one of the questions I probably will pick up now when you've talked about. So what is your cutoff? Is there any cutoff when you say, oh, enough is enough, this size or these aggressive signs, I'm not going to try, waste my time? You rather have replacement fusion?
Individualized decision. You know, some patients come along with a larger than life lesion. You know, I often say to patients, if you want one operation to guarantee success here, then it ain't going to be what we've talked about today. If it's a big lesion, so it's down to the individual patient. If they're prepared to give it a go, then I'll try anything on them.
What is a big lesion, Steve? Is it 2.5, 3, 4?
It's relative to the patient, and if there's reciprocal changes, you know, so a smaller lesion with reciprocal changes on the tibia will be more advanced in my book than a larger isolated unipolar lesion. So you can't give a generic figure. I don't think it's just how you're feeling, your gut feeling on the day with the patients and the scans. I don't know if you're any different, Pete.
Yeah, no, that last image I showed you, which was those nested plugs, that was actually on a BMX YouTuber who's broken his ankle so many times. It was really arthritic, but he didn't want to have a fusion, and he had one big area on his talus, and he said, "Can you do anything?" I said, "Well, we can try some osteochondral grafts if you're prepared to go with it." And give it a go. And he said, "Yeah, I'll try anything because I need to keep riding my bike." And he had early arthritic changes, and he's delighted. So yeah, it's very, very individualistic.
As long as patient is well informed, then obviously doesn't matter size or other. Okay, fair enough. Thank you. Next question is from Edward. What is the natural history of cystic lesions in adolescents? Likely to resolve?
I'll pass that one over because I don't do children, I'm afraid, anymore. My theory is that they don't resolve in the long term. They might get better. I think they have a symptom-free period or a symptom easing period, but they do come back eventually, is my view.
Yeah, they're very uncommon. I think if they remain symptomatic over a long period, then treat them depending on whether you think a retrograde drilling is the right thing. I would probably keep that in skeletal maturity. If they're skeletal mature, then I would treat them as I would an adult and debride it. So you're kind of looking under 14s, you'd retrograde drill, and over 14s, you'd treat as an adult.
But natural history, Pete, do you think they might get better with time if you wait?
I don't know. I don't know the answer to that.
No, fair enough. We don't know the answer, Ed, sorry. Next one is from Asad Syed. What is the preferred treatment for shoulder lesions? Any preference, anything?
Well, I take it most of my lesions are shoulder lesions. The central talar lesions are much less frequent. So most of them are close to the shoulder. And so everything I've talked about applies to shoulder lesions, and I'm sure the same for Pete.
Yeah, I suppose he's talking about the ones where it really is, where it slips over the corner, rather than being sort of planted on the top of the shoulder.
Yeah, well, it's not
different. Yeah, and no different, and probably they probably do a bit better because they haven't got quite the same hydrodynamic pressures on them. Yeah. I would guess. So no different to normal. Debridement first.
Yeah, thank you. Okay. Next question is nanofracture versus microfracture. What is nanofracture? I don't know, guys.
It's using a very small probe rather than the big standard ones. Well, the first thing is I don't really do microfracture. I tend to just do debridement and slight burring of the surface of the bone. I don't think there's any evidence over one technique better than the other. I'm pretty sure no one studied nanofracture specifically against microfracture, so it might be better. I think it's just still achieving the same thing, which is a bone marrow stimulation type of procedure. So I can't imagine it'll be heaps better, but we'll wait and see.
So it's a different kit then for nanofracture?
Yeah, it's just a very defined probe, basically.
It's quite a neat probe. I mean, technically it works really well. It's got its own little handle on it, so it's much easier to use than a microfracture pit.
It makes sense because microfracture was essentially designed for the knee, wasn't it? And the probe was very difficult to use. If you get the old blunt microfracture probe out of the knee set, and you hit it, and it skives off and takes off another load of cartilage, and you just increase it. Yes. I think nanofracture when it's a new, because I think they're single use, aren't they? So they can be you get a brand new fresh one every time. That's not a bad thing to use. So I wouldn't talk against it. Absolutely.
Thank you. I think we have already discussed this next question from Olga Jones, that in which scenario you would bypass all these techniques and go for fusion. I think we talked about that, haven't we? So there are quite a few other questions. So I'm going to go to the next one then.
Steve, can I ask you, why don't you do microfracture? Because I don't either.
For that reason, because I've just never found the probes very user-friendly. If the lesion's right at the front, yes. But if the lesion's more than a third of the way back, it's easier to access just using a curette or a burr or something like that than it is with a microfracture probe in my hands.
Mm-hmm.
And most of these lesions have already perforated the subchondral bone anyway. The ones I'm attacking, I'm getting. It's very rare that I get a largely chondral flap and the subchondral surface is intact. They've already broken through or crumbling, or there's a cyst or something, and it's easier. Once you've exposed the subchondral bone, that's what a microfracture is. So once you've got bleeding, you've got your bone marrow response.
So what you two are saying, that if there was a randomized controlled trial about different techniques of bone marrow stimulation, then what we usually call microfracture probably won't be the...
Yeah, that's been proven 10, 15 years ago, that there's no difference between drilling, microfracture, or burring. And that's why they were massed together in this bone marrow stimulation technique. And they're all bone marrow stimulation techniques, which is why I said that nanofracture is probably the same, but it's just a little bit more precise than microfracture probably.
Thank you. Next one is from Steve Milner. The question is a UK RCT ever possible when each of us will only see a small number of failed microfractures? Maybe a registry approach would be better?
Yeah, I completely agree. I mean, I about 4 years ago, I started on this. I'm not the world's greatest researcher, but I did get a very keen fellow once who was keen to try and set this up, but it is a nightmare to try and set up a RCT in this condition because there's so many things that aren't standardized and difficult to do. You need a good group. I think it's possible. I don't think the numbers are that small if you get a few groups together. But it is difficult, and there are a lot of different things that need to be analysed. A registry approach might be better, but we now have reasonably good evidence that a certain size of lesion we could randomise into 1 or 2 or 3 different treatments. It's homing down into microfracture, AMIC, and OATS really. I mean, there are other things coming out, but they're a long way behind those 3 treatments. And so there is the opportunity there for someone to do it. And, you can see that Martinus Richter is publishing 130 in a year. Well, if he can do it, then other people should be able to with a bit of coordination, but it will be difficult.
Pete, do you have anything to add?
No, I think it's like all these things, isn't it, where there are small numbers. And also you're in second time round surgery, so your pain generators are going to be not necessarily simple from the osteochondral lesion. So it's going to be a very difficult thing to get decent figures out that aren't complicated by where all these pain generators are coming from. So, tough.
Thank you. Talking about size, so Roland Russell is asking each of you individually, what is the largest talar lesion you've successfully treated with AMIC and with OATS?
Well, with EMIC, I'm just trying to think what's that. I don't usually measure them, but I'm thinking this largest patch I've cut. The patch comes in the smallest patch comes 3 by 4 centimeters, and I've probably used about 25% of that is my biggest lesion that I've successfully treated. So whatever that works out, can't remember. A quarter of a 3 by 4, so that's 1.5 by 2. Yeah, there you go, 1.5 by 2.
So I've done one with 2 10s and 2 8 plugs, so whatever that is, 10, 10, 36. So 2 10 diameter plugs, 2 8 millimeter diameter plugs. I've no idea what surface area that comes to.
So thinking about it, when you can go quite big, I mean, you've shown the example where there were lots of areas, and was that progressive? I don't know whether that was rheumatoid or anything, because you put some plugs which were very nice, and then there were other areas which developed afterwards.
Yeah, yes, she was an interesting case. I'm not sure whether that was just there was like the video one I showed. I think she just had some, cartilage failure disease and from her ankles, and I don't think there was any pathology with it. From memory, she was a model for L'Oreal or something. That was all. But
you get a different class of patients than I do, Pete.
That's Pete's specialty.
I wish it was.
Next one is any experience with cryopreserved live allograft scaffolds?
Simple answer, no. I mean, live allografts are so damn difficult in this country that I've not really toyed with the idea. We don't have a HTA license anymore in Bristol. We lost it for various reasons. So doing that sort of thing is really difficult. And I've just not got the motivation to try it, to be honest. And
there was, Steve, wasn't there always that thing of how live is live? I mean, the cell drop-off rate is very rapid, isn't it? Yeah. So I think in the end, you're just ending up putting in an allograft.
No, I have to say, my experience with anything bigger than an oats plug is very limited. I haven't done any large bulk allografts on the talus at all, really. I just can't believe it's going to work.
Okay, so the answer is that.
Call me skeptical, but yeah, that's my opinion on it.
I mean, Mark Marson was a big, like he often is, he was a big fan of it for about 2 or 3 years, and then came out and said, "Oh no, this is terrible. It never works." So he certainly had his fingers burnt with it.
Not a good choice then. Thoughts on AutoCart?
Well, it's funny you should say that. You can't use AutoCart in this country. Oh, sorry, AutoCart you can. You can't use BioCart. Yeah, you can use AutoCart in this country. And I've done one case. And I don't know the outcome because I did it 3 weeks ago. So, yes, I've got thoughts and I've been experimenting with it. But I don't have any results because it's a relatively new technique. It's fiddly. And it's difficult to get the volume of cartilage you need from around the lesion. Then you end up having to take extra cartilage from the anterior neck of the talus to get enough cartilage to provide the graft. So it may be a technique. I mean, it's the sort of this has sort of come from the evidence in America of the use of juvenile particularized chondro grafting that they use, ground up children's cartilage, which we just can't use in this country. So this is an equivalent of that, where you take the patient's own cartilage, mix it with some, PRP essentially, and use the patient's own blood to provide the fibrin glue. Yeah, I mean, it might work, but the jury's still out. I don't think enough cases have been done. It's an interesting topic, an interesting technique. It probably needs to be researched. I used it in a case. This is the problem, that these new things, I'm only really trying them when everything else has failed, and so the expectation that they're going to work is pretty slim, isn't it? I mean, this guy's already had a chondroguide and it failed, and now I'm doing something different that's not got much evidence behind it. So the chances are it won't work for him. But if we get a good result, like Pete did in his first oats, then maybe it'll become the new best thing.
Yeah.
But I can't give you any better science on it than that.
Thank you. We're just going to take 3 final questions. We have run over the time, but I think it's important that we try to answer all the questions. Howard Tribe, I think, Steve, it's to you. Have you used chondroguide in any other joint, such as first MTP joint?
I've used it once in an MTP joint. I did notice when I was looking at the literature that, again, the Germans have published on about 40 cases in the MTP joint. It was marginal benefit for the patients I did, but one swallow doesn't make a summer. So I don't know what the long term is. There's no harm in trying it because the other options are not great either in the MTP joint.
Do you do arthroscopy and debridement, Steve?
I have done, but I wouldn't do this. I wouldn't do the chondroguide arthroscopically. No, it'd be too difficult, I think. Because
arthroscopic debridement is pretty good in the first.
Yeah, it works, but on the very central lesions, it doesn't work very well, I don't think. I mean, I'm not. Again, it's the same thing, isn't it? It's the decision of whether you do it as a primary technique or you reserve it for failed whatever primary procedure, and that's the distinction that needs to be made in these papers. And all of these AMIC papers are based on using it in primary cases of mixed size lesions. They're not standardized, and until we standardize the size of the lesion and we randomize between that and microfracture or that and oats, we're not going to know the answer. And so anything's possible. Everyone's got free justification to do what they feel like. And what will happen is you'll do 2 or 3 of one case, and when you find out what works best for you, that's what you'll use.
Yeah. You're very swayed by your experience.
Yeah.
Exactly. That's the problem, isn't it? When you haven't got evidence, then you wouldn't sort of experiment it. You rather go for the time-tested techniques rather than these non-evidence-based.
I mean, I think for the summary for the people who are still listening is, you microfracture still has a role, certainly in smaller lesions, and whether you do that with microfracture or drilling or nanofracture, whatever, it doesn't really matter. And then in the bigger lesions, whether they're primary or revision, the two main techniques are some form of membrane and oats. And then there's a whole lot of other things like the autocards, like the episealer, like, spinal iliac crest grafts, which no one can support with any reasoned evidence. And that's the summary, really, for me.
I mean, we're getting such good results now with AOT or oats. It's going to be quite hard to beat, to be honest. The evidence now for those big lesions is really strong for AOT, which I think is interesting. And I do it more now than I used to, just because you get more confident with it, and you get more confident that you don't cripple the patient by rubbishing their knee and attacking their ankle. And I think you'll start to use it more and more, like all these things. Use it for specialized cases, and then it'll creep into your more routine practice, as I'm sure you do with AMIC.
Whilst you're there, Pete, on that, can I just ask you, so for example, God forbid, it doesn't happen, or it happens rarely, but if somebody develops quite significant knee pain, you've taken only 2 plugs, what do you do? I mean, how that is resolved then?
I give them to the knee surgeons.
Simple answer.
Takes an osteochondral graft from the other knee and puts it in the knee.
They will take graft from talus and put it in the knee there. Huh? Okay. We had this debate about microfracture and nanofracture. So the question is that, can microfracture cause damage such as intralesional osteophyte changes?
I have to say, I have no opinion on that. I'm not all favor with the paper that's being referred to, is the honest answer.
No, me neither.
No, I've never heard about this sort of issue. Okay. The last and final question, we have run well over time. So it's from Matt Solan. So should papers using clever techniques as a primary procedure rather than a salvage after 15% or so that fail microfracture be excluded from reviews or meta-analysis, etc.? Do the good results they present give a rosy view?
That's certainly my view, is that, I don't think it should be excluded from the literature, but they have to be highlighted for what they are. They're just case series of all comers getting the same technique, and you have to realize that you can get similar results with very simple techniques. But what should happen is we should be putting them as a randomized controlled trial of some way, or even a case control experiment or something like that, rather than just choosing, I'm going to do this operation on the next 100 that I see, and I'll publish good results, because you'll just constantly publish 85 to 90% results if you do that, because pretty much anything we do to them gives us that. What we want to do is find out what the best technique is for individual lesions. That's my view anyway.
Pete, any final comments?
Not on that, but I have got a question to both of you. Is what do you do if you're, and this happened to me the other day, so you're in the ankle and there is a pretty decent sized medial osteochondral defect, and it's it's on the equator, a bit of it's off the back, you think, yeah, I can get to that, and then you get into the ankle and you can't get anywhere near it. What do you do in that situation?
So just say again, but you can't get near the lesion on the medial side.
You just can't access it. The joint's clamped shut, and you just can't get. You can't even get you can't see it. You can't get your camera into view it. You can't get your hook into there.
Yeah. Crank up the traction a bit more, and then. But no, I mean, you do get it. Especially you get that occasionally on the second look. You know, some people who have an arthroscopy get an abnormal scarring reaction and get a very tight ankle the second time you go in. And you can tell almost as soon as you put the scope in, you're not going to get very far. I don't have a solution. Sometimes you have to abandon ship and just admit defeat. You might have to, if you're going to treat it, do a malleolar osteotomy to get to, you know, even to treat it simply, you might have to do a malleolar osteotomy. Some people did talk about transmalleolar drilling, so you can, you know, put a drill through the medial malleolar into the lesion, and then sort of back the drill out, move the ankle a bit, drill goes in again, move the ankle a bit, and just get a few drill holes into it. I've never done it, but it was talked about many years ago. There was also reported incidence of stress fracture of the medial malleolus afterwards, but you know, that's one option maybe.
Yeah.
I mean, you two guys are much more experienced than me, and I would agree that, you know, if you can't access it arthroscopically, then you've not consented the patient, you're not prepared for malleolar osteotomy, then abandon the procedure and go back as a second stage if required with an open procedure such as osteotomy.
Yeah, yeah. Good.
Okay.
Well, it has been really, really interesting, and I'm sure everyone, I certainly have learned loads and enjoyed it, and people have given their time stayed well past 9 o'clock, so 22 minutes past 9. I don't mind running over because it's really good to get our discussion going. Thank you so much once again, Steve and Pete, for this fantastic session. And please, audience, send us the feedback so that we get the encouragement as well as, you know, make this Master Techniques episode better. Also, give me the suggestions if you have any burning thoughts about what the next topic should be for the Master Techniques, which we most likely will do in April. Don't forget to give us the feedback and get your certificate. And once again, thank you everyone for being with us, and look forward to meeting you next time. Have a good evening.
Thanks so much, Maneesh.
Thanks.